Can I ask Marta and Michelle to come up and have a seat behind their respective name plates? So this session has about another 15, 20 minutes, and I'd like to open this up to the audience. We're calling it Town Forum, I think, but it's really question and answer. So if you have a question, I would like you to come to the microphone and ask any one of our panel. And while you're thinking of your question, I will ask a question. So, Suzanne, one of my questions is, when I looked at your data originally and hearing it again now, the question is, how good was the pre-pregnancy weight, particularly in those women who are overweight and obese? My assumption is that they would tend to underestimate their pre-pregnancy weight, and hence their weight gain in early pregnancy might be an overestimate. Your comments or thoughts?
Yeah, so I was hoping that it would be an overestimate of their first trimester gestational weight gain. We did a study comparing self-reported pre-pregnancy weight in this very study and chart abstracted measured weights, and the correlation was 0.96, I believe, with a half kilo difference underreporting of weight. So they're pretty highly correlated. Other studies have found larger differences, but in this study, and we did analyze the data using measured pre-pregnancy weights and found basically the same percentage in that subset on whom we had measured pre-pregnancy weight.
Okay. Andrea?
Yeah, I kind of wanted to follow up, I guess, on the first trimester weight gain. I'm working on analyses right now where we are using serial measured weights during pregnancy, and we're seeing that the first trimester gains are much higher than the assumed 5 pounds kind of range. And so I'm just wondering if there's a way that we can sort of catch those women early, and regardless of what their BMI is, if they're already above that threshold, get them in to see the nutritionist or follow up or things like that. And if that's really sort of a missed opportunity right now, an opportunity that we're missing right now.
Comments?
Yeah, I completely agree, and I'm excited that we're seeing women coming in earlier and earlier in terms of gestation, although I know there's a lot of variability, but I think any effort we can to promote women coming in, as we've been saying, pre-conception, early in conception, it would be, like you said, we don't want to miss that opportunity if we can create it.
And I'll just follow up in that particular data set we're looking at. These were all underweight, normal weight women. These are not overweight women.
Yeah.
Marta or Michelle, any comment on that question either?
The only comment I would make too is to keep in mind also high-risk populations and the need to try to get them into pregnancy, prenatal care as early as possible as well.
Yeah, we need to put stickers on, pregnancy tests saying, go get treatment if you're pregnant.
Hi, so, yeah, very interesting work. So I'm wondering, should pregnancy weight gain just be treated as just weight gain and just normal activity, in the sense that if there's no difference in the modalities that you can use in pregnancy and outside pregnancy, then why should we separate it? And so my question is, things like Weight Watchers and other standard weight reduction programs, has anybody tried to use that on pregnant women and see whether just putting them in those regular programs will work?
I think although the strategies can be applied to pregnancy, they're applied differently. Weight loss is not the same as preventing excessive weight gain. That said, like I was showing before, I think the same strategies work in modifying weight regardless of the period of time in a woman's life. I think that I don't know if Weight Watchers are commercial programs. I know the Weight Watchers has an online pregnancy intervention, but again, it's preventing weight gain is different from weight loss. We know there's still a lot that we need to know about weight gain in pregnancy. What are the specific calorie goals that should be used? And a lot of work that has been done outside of pregnancy, I think we can apply to pregnancy, but we're just not quite there yet to be able to say the same. It's going to be treated the same.
Yeah, and that's important. I just want to maybe just comment also on another principle that seems to be coming up over and over again, and that is the outcome of pregnancy is determined the first 3 months of pregnancy. And that's the time we only see them infrequently, and that's the time we don't even know that they're pregnant. So the question is, because also refers to other things. Other people have looked at preeclampsia and prematurity and all these other complications of pregnancy. And it appears to be whatever occurs in the first trimester, if you don't change it, then it's too late. So the question is, how do we change a paradigm to looking or taking care of women in the first trimester? And that's open for everyone.
Yeah,
Yeah.
harkens the question, it begs the question, how do we get them in? How do we motivate them, to know they're pregnant early enough,
Exactly.
and then two, to go in to get care. So I think that's a great question.
Michelle, any comment on that relative to HRSA? Looking at that? Suzanne, would you mind just hitting, thanks.
Well, certainly, actually for the state Title V programs, entry into prenatal care is one of the national measures that our states report on, and it's just an ongoing battle. And as was said earlier, many of the pregnancies are not planned, so trying to get people to do what they need to do prior to pregnancy and then to get into the healthcare system early in pregnancy is a challenge. I would add, though, I think this is one area where interconception counseling can be really helpful, and you may miss the first pregnancy, but through programs like WIC and some of our programs where we are following the mother and the child after birth, it's a good time for education really to help prepare the mother for the next pregnancy.
Yes, I would say that in the WIC community we are looking at what we call the postpartum period as really the preconception period for the next pregnancy, and so I think we can stand to put more emphasis on that in that perspective rather than just the postpartum from the previous pregnancy.
Anna Maria?
So my comment and question sort of follows up on what you've been talking about in the sense that most of our research has started way too late. So we're starting at the point when they've already been set on this trajectory, whether it's the trajectory of the pregnancy or the trajectory of that weight gain during pregnancy. And we don't know enough about having a supportive environment and healthy lifestyle to really help women prior to becoming pregnant. And I think we need to move there, because if you start monitoring what happens when they come in around 12 and 13 weeks, and even if they come in at 8 weeks, some of them might have blown it. And we don't know whether that's because they were overweight or obese and they were told to lose weight to become fertile, and so now they've conceived, and yet now they think, well, I can relax, but you can't relax. And so I think there's lots of paradigms that need to be fixed. And so what we said in that report, that we're going to need a radical change is very, very true. So I think the idea of actually, front-loading visits is excellent. I think we might want to try to front-load visits as soon as a woman becomes married, as soon as a woman graduates,
Do you want to limit it just to people who get married?
I think we're missing a very important time to actually intervene in women's lives, to get them on that right trajectory. And I would love it if, in fact, our state programs could sort of think about some of those activities that we can do that target women that much earlier.
Isa?
I wanted to add on to Anna Marie, but I had a different question why I was coming to the mic. But I think one of the opportunities to get women is, so what we see is, they follow their pediatrician or their family physician all the way up to 18, right? And then they head off to college. And so I think that there's a real opportunity to use some of the infrastructure within the college system that I don't think we think about, student health services and understanding where young college women are getting their care during college, because they are getting contraception and they are having, gynecological issues. I mean, now the pap smear is not necessarily in that time frame, so to speak. So I think maybe starting with understanding what the infrastructure to help support the women through college, and then once they get on the other side and they're ready to start thinking about having a family, now they can seek their patient-centered medical home, because now they're working and they have benefits that they can transition off there. So I think, that's one area that we could start to understand better. The other thing, though, I wanted to go back to the gap about women getting in early. So there's a little bit of a conflict that happens. I mean, I think when women become pregnant, they're very excited and they do call and they do want to come in early. But a lot of OBs and a lot of physician practices will not see a woman before 8 weeks or 11 weeks. They want them to get a little bit further along in their pregnancy before they actually will do that first prenatal visit. So I think there is going to need to be a cultural shift on the medical side to open our practices up to receive those women earlier when they are 8 weeks and they're calling, or 6 weeks when they're calling. But again, right now, many physicians won't necessarily see them until they're further along. And so what do we do in that time frame?
Comments or thoughts?
I loved all your points. The one thing as a researcher thinking about intervening in college, the thought that I have is what a long study would have to be done, because you'd have to intervene in college and then follow them through pregnancy and delivery. And so I'm just thinking of designing, such a study.
10 years isn't such a long time.
I'd just like to comment on, I think, Suzanne, you hit the nail on the head. I'm trying to design a research project right now, and I've read all those articles that you put up there, and I came up with the same results, was that the only, I couldn't write fast enough, but those 4 top ones where the yes was, those seem to be the only interventions that really seem to be working, is the behavioral, diet. Do you remember what they were?
Calorie goals, self-monitoring, weight monitoring, ongoing contact, moderate physical activity. And I think the slides are available, publicly available.
And you gave the reference to in the AJCN.
Yes, the AJCN paper, and there's paper in Women's Health.
And the other piece I liked was, one of my other thoughts was that toolbox that you had there, which is something I envisioned, something with some of these resources here, as well as that cookbook that I just learned about from SNAP, as well as the tracking, so actually giving them, but then that begs the other 2 ends of pregnancy, before and after. Thank you.
Thank you for your comments. Marvin?
So this question's for Suzanne. It flies in the face of everything you've concluded, so it's really not fair. But as someone who's also done a fair amount of behavioral change research, or efforts to change behavior, I appreciate throwing everything but the kitchen sink in to try and achieve some change. But most of what we heard this morning was there's no time. It's hard enough to involve OBGYN people or any other kind of healthcare provider. If somebody forced you to prioritize different parts of the intervention, albeit you've already documented it, one piece doesn't work at a time, how would you prioritize if you had to?
That's a great question, and I'll be a little bit evasive first. In that I think there are options around, there are choices that we have to help save time in the practitioner's office. And one of the things that's worked outside of pregnancy is using internet-based programs that can be comprehensive, that can be accessible, and can be convenient for patients. So I like to think that there's ways around ways to save time in the practitioner's office. It's hard to pick and choose 1 or 2 things. Structured meal plans, ongoing, it's really the combination of approaches. And I think the solution is to find a way to implement that in a cost-effective way, and doing cost-effective analysis showing the savings that can occur by implementing and spending the time to implement and money to implement such programs that can save money. So I don't think I can pick 1 or 2, because it is, I'm sorry, the package.
I told you I thought the question was unfair.
It's a good question.
Okay. One last question. I can tell it's burning someone's... we'll go over here, just because... go ahead. Dotem can save his question for the next speaker.
It's stunning to me how your review of what elements of a program or intervention seem to be most effective. The way that it mirrors the work around sexuality, sexual health for adolescents, and the same findings are so robust. Is that it's the comprehensive approach to what we do. And one of the problems in the research, and the late Doug Kirby who has looked at dozens and dozens of sexual health programs, have found that when people try to a la carte and they don't keep the fidelity of the protocol for what seems to work, then we start to get confused again and say, well, what does work, what doesn't work? And I think, and another issue and challenge that we have is that when we propose in grant proposals, research grant proposals, a plan that replicates with fidelity the interventions that have been shown to work is not called innovative anymore. So it's just sort of a heads up to, because I think it very much is what we see around sexuality education for young people. The good news is you all don't have political forces telling you that it's immoral to weigh yourself or whatever.
Not yet.
So I just think it's tremendously helpful and good work.
Okay, well, thank you very much to our three speakers and your questions. Okay, our next speaker for this session is going to be Richard Sass. The official introduction is that he's the chairman of the Contact Wellness Foundation in Portland, Oregon. He founded Contact Wellness as part of his personal contribution to healthcare reform, representing his desire to move beyond the delivery of innovative medical products, which he has a long history of, to the creation of motivational tools leading to positive changes for those living with chronic disease. That's the end of the official recommendation or introduction. I've known Dick for maybe 2 or 3 years now, and while Michael Liu talked about thinking outside the box, sometimes I think that knowing Richard a little bit, not only does he think outside the box, I think he was born outside the box, and he can think big, and I think as a private citizen, his thoughts are good. It gives a good balance to this program. So, Dick, welcome.